Welcome to the Sound of Ideas from IdeaStream Public Media. I'm Stephanie Haney. Thank you for being with us. Infant mortality refers to the death of a child before they reach their first birthday. In Northeast Ohio, the rate of these tragic deaths has consistently been over double the national average. Among these fatalities, there's a higher likelihood that Black babies won't make it past their first year, partially due to lack of access to care and education, along with financial stressors. In Summit County, for example, data.gov shows the infant mortality rate for Black babies in 2024 was just over 19 deaths per 1,000 live births. To compare, the national rate that same year for all infants was close to 6 deaths per 1,000 live births. This discrepancy isn't an outlier in Summit County, where the infant death rate for Black children has been rising since it first hit an all-time high in 2011. Why are Black babies, especially in Northeast Ohio, at higher risk for early death? And as we've seen, all babies in the state of Ohio. And what efforts are physicians and community members taking to reduce these fatalities? Joining us in the studio today to try to answer these questions, we have Jessica Wilder, a maternal and fetal medicine doctor in Metro Health's Department of Obstetrics and Gynecology. Dr. Wilder, thanks for being with us.
Thank you for having me. I'm glad to be here.
We appreciate it. Also with us on video call, we have Krista Lumpkins Howard, Senior Director of Training and Community Outreach at Birthing Beautiful Communities. Krista, welcome to the show.
Thank you so much.
Later, we'll hear from an organization in Akron working to decrease the number of infant fatalities in Summit County. If you would like to join this conversation, maybe you'd like to share an experience you've had or a question or a concern that you might have, you can give us a call at 866-578-0903. You can also email us at soi@ideastream.org. You can also message us on Instagram at The Sound of Ideas. Now, Dr. Wilder, can we start at a high level here? And can you tell us what are some of the reasons that babies don't make it to their first birthday?
Yes. So we know that infant mortality has multiple causes. The leading causes that we see in both county data as well as state data include birth defects or congenital abnormalities, prematurity, which means delivery before term or delivery before 37 weeks. We also know that unsafe sleep, as well as sudden unexplained death, contribute to some of the infant mortality rates that we see here in our region.
Would that be considered an environmental factor, or is that something else, environmental factors that might play into this?
Well, we think it's a combination, but what we think is largely driving the disparities we see between Black and non-Black individuals has a lot to do with environmental issues as well as systemic issues such as racism and poverty.
Thanks for sharing that with us, Dr. Wilder. In general, you mentioned the disparity there. We've been talking about the disparity here for a moment now. Who is at higher risk of losing their baby before their first birthday as we look at things here in the state of Ohio?
In the state of Ohio, we know that African American or Black families are at significantly high risk for infant mortality, as well as all-cause morbidity and mortality related to pregnancy. When we specifically look at Northeast Ohio, we can see that there is a lot of historical vestiges of racial redlining. And a lot of the infant mortality trends follow those redlining trends that we have seen historically in Northeast Ohio.
And when we're talking about redlining, we're talking about the historical practice of denying mortgage loans to non-white people, of putting people in certain neighborhoods based on where they were able to get loans in order to secure housing. Can you also talk to us about some of those comorbidities, those chronic health conditions that might be an issue when it comes to what increases the risk of a baby not making it to their first birthday?
Absolutely. So we know that with systemic racism and poverty, individuals are likely to be living in areas that might be food deserts. Individuals may be likely to be living in areas where they don't have access to fresh fruits and vegetables, or even access to a pharmacy that stays open, 24/7. And so without appropriate nutrition, there's increased risk for chronic health conditions like hypertension or high blood pressure, diabetes, and even obesity. And all of those things increase the risk of having a preterm birth or even increase the risk of infant mortality. We also know that stress is a large risk factor for preterm birth. And we don't necessarily have a clean way to measure or a perfect way to measure stress. But when you think about systemic racism as well as poverty, all of those things contribute to stress and increase the morbidity and mortality for our moms and our babies here in Northeast Ohio.
Dr. Wilder, have you seen anything related to preeclampsia and an increase in some of the populations we've been talking about today? I know preeclampsia, high blood pressure at the end of a pregnancy or at any point in a pregnancy, can lead to preterm birth, which we know, as you've been saying here, can lead to a lesser likelihood that a baby will make it to their first birthday. Is there a disparity in preeclampsia rates that you've seen here in Northeast Ohio among Black, Hispanic, and white people?
Absolutely. The disparity for Black families and women exists when you think about all pregnancy complications as well as all chronic medical conditions, and preeclampsia is no exception. Preeclampsia is a condition that includes elevation or high blood pressure, as well as conditions that affect the liver and the kidneys for pregnant people. Preeclampsia can develop very early in a pregnancy, such as the second trimester. Preeclampsia can also develop in the third trimester, but it is most dangerous when it develops early in a pregnancy, and that's when it increases the risk for a preterm birth. Understanding preeclampsia is challenging. We know that preeclampsia has many risk factors, being of African descent, being an older pregnant person or a younger pregnant person increases the risk, being a first-time pregnant person, or there being a large gap in between your pregnancies, like 10 or more years, all increases the risk of preeclampsia. And so we think when we are looking at the disparity in Northeast Ohio, we think the chronic or unmanaged chronic medical conditions is contributing a lot to the disparity. We think that stress is contributing. We also think that concerns with access to getting care, timely care, is also contributing to the disparity.
Okay. Something that we have seen in research that's been published by multiple university systems is low dose aspirin as a treatment for preeclampsia. Is that something that is part of the protocol at Metro Health?
Yes. So Metro Health recently implemented a universal low dose aspirin protocol, which means that all pregnant individuals are advised to take low dose aspirin starting at 12 to 13 weeks of their pregnancy. We decided to move forward with a universal protocol so that we can decrease the chance that we would miss counseling any person. We know that many individuals in Northeast Ohio are at high risk for preeclampsia and have many risk factors that would already suggest that they should be taking low dose aspirin. And so we've gone to a universal protocol. We are also starting to investigate what does it look like for us to dispense the aspirin on site for our pregnant families. We recognize that many families do live in a pharmacy desert, and so if we're using aspirin as a way to reduce the risk of adverse pregnancy outcome and infant mortality, how do we then take the next step and overcome the barriers that can exist with pharmacy deserts and actually dispense it in the clinics so that patients can walk out of their doctor's appointments with aspirin?
Okay. Krista, can you tell us about your work as a senior director of training and community outreach for Birthing Beautiful Communities?
Absolutely. So in my role, I wear two hats. One, I have the honor of training all of our doulas to become doulas in Cuyahoga and Summit counties. I'm creating this workforce development of doulas and what that looks like as we are working diligently to create a scope of practice nationwide on what doulas do. And then on the second part, it's about community impact. So getting out in the community, making sure that people understand what doulas are, how we do that. We've really been working with Northeast Ohio hospitals with the Doula Integration Project. And with this, we are working with Metro, University Hospital, and Cleveland Clinic just to really inform providers with the team birth model on how to incorporate doulas as part of that huddle conversation when it comes to a birthing person's care.
And can you tell us, Krista, specifically what Birthing Beautiful Communities is doing to promote awareness and information about infant mortality here in Northeast Ohio?
Yes. So our doulas are out in the community as well. We go to community events often. But in addition to that, we are building a freestanding birth center. So the excitement around the birth center coming, it creates an alternative to giving birth in a hospital setting. So they will have that opportunity. In addition to that, we are spreading the word about our work and what we do and how doulas do have an impact in decreasing some of this infant and maternal mortality rates in Northeast Ohio.
Thanks for sharing that with us, Krista. If you're just joining us here on The Sound of Ideas, we are talking about infant mortality rates here in Northeast Ohio. We do know that the rates in our area are significantly higher than the rates of infant mortality across the country. That's nationwide. And then also here in the Northeast Ohio area, the rates of infant mortality for Black babies and Hispanic babies are significantly higher than those for white babies. If you want to be a part of this conversation, the number to call is 866 578 0903. You can also email us at soi@ideastream.org, or you can send us a message on Instagram at The Sound of Ideas. Joining us now, we have Lakeish Duke, the Executive Director of Project Ujima. Welcome to The Sound of Ideas, Lakeish.
Hi, good morning. How are you?
Great. Thank you for being with us. Can you tell us more about Project Ujima and your involvement in infant mortality research, Lakeish?
Sure, love to. So Project Ujima, Ujima named after one of the principles of Kwanzaa. It means collective work and responsibility to make our brothers and sisters' problems our problems and to solve them together. And so the organization is a community engagement organization, and we teach and facilitate a discussion circle process. That process we call peace circles, and those circles is how you bring people together around a shared issue or concern, find common ground, build relationships of trust, and then move the conversation from talk to action. And so I think what we're used to doing in our community and maybe even around our dinner tables is complaining about a thing. But what we often lack is a process of how we bring people together around that shared concern, understand that relationships and find that common ground, and then move conversation from complaining or talking about it to that action piece. And so we teach and facilitate that discussion circle process in our community and have done so since 2011.
Mm.
And we came on the infant mortality scene in 2017. That's when our community initiated our full-term first birthday initiative to address the infant mortality in our community. And so we started out with our centering program in 2017 in partnership with our local hospital system, Suma Health System, and Minority Behavior Health Group was a um, uh, culturally appropriate or culturally centered therapy for the women. And so we met at least twice a week to do that centering program for the women in our community. And that was from 2017 to 2023.
Mm. And can you tell us, Lakeish, more about the Queens Village project within Project Ujima?
Sure. So Project Ujima is our nonprofit, and Queens Village is the program that we offer to the community to address our infant vitality in the community. And so Queens Village started about 7 years ago in Cincinnati, and it's a supportive community of powerful Black women who come together to rest, relax, repower, to take care of ourselves and to take care of one another. And so we exist to decrease our, to address the racial disparities in birth outcomes and the conditions that drive those inequities in our maternal and infant health.
Mm. If you're just joining us here on Sound of Ideas, we are talking about infant mortality, which is the death of a baby anytime from birth leading up to that first birthday, and the fact that the rates here in Ohio are significantly higher than the nationwide rates for those fatalities, and that here within Ohio, the rates of Black and Hispanic babies who are dying before their first birthday are higher than those of their white counterparts. If you want to be a part of this conversation, the number to call is 866-578-0903. If you want to email us, you can at soi@ideastream.org, or you can send us a message on Instagram at The Sound of Ideas. We have a call now from Todd in Ward 1. Todd, welcome to The Sound of Ideas. Please go ahead.
Stephanie, Krista, Jessica, Lakeith, and I think there's a Dr. Wilder. Is that Allison? This is a topic that I actually studied, and I've studied it for decades, and I mainly focus on the 4 Federal Reserve districts, which are multiple states that are of most interest to me: 4, 5, 6, and 7. Cleveland's in 4. Cleveland's not a rural area. Neither is Metro Akron. Educate me a little bit better on this and your understanding as a group. Do you consider, any of you, this a contributor? Poor or no preparation prior to conception to be a parent as being a contributor to what often becomes infant mortality. There's plenty of education available in the metro areas, plenty of education. And in addition to that, if someone knows that they're poor in advance prior to conception, they have the opportunity to make the decisions on how to maneuver through becoming a parent and raising a child. And then the second question is this, and this is important. What do you qualify as being a poor access to education on how to get a child from 0 through year 1?
Thank you for the question, Todd. Dr. Wilder, I'll ask you first to address the question of Todd's question about planning prior to conception, if that is a contributing factor to infant mortality here.
Thank you for the question, Todd. I do think that education and lack of planning can be contributors. However, when you look at the disparities in maternal mortality and morbidity, as well as infant mortality and morbidity, and you take individuals that are well educated, who have access to lots of resources, they are still going to be at a higher risk for infant mortality as well as maternal morbidity and mortality. So yes, does education and preparedness make a major impact? Yes, but there is also a larger systemic issue, particularly when it comes to racism. I think that also contributes, and that's why you can see these disparities exist regardless of how well educated you are or how well prepared you may or may not be for pregnancy.
Krista of Birthing Beautiful Communities, I'll ask you if you could address the question on what it means to you for there to be a lack of access to education on what is necessary or what would be helpful to get a baby to that first birthday.
Can we pivot a little bit from education? I would like to say having a baby is the one time where we need to trust our intuition. It's the one time that our bodies working holistically with the baby are going to actually deliver the baby, right? So there is a component of education, but we also need to kind of trust ourselves. And I think being prepared is something where childbirth education, nothing really prepares you to be a parent, right? I mean, there are books, there are manuals, articles, things like that, but it's the one time where we really need to trust our intuitiveness to holistically give birth. And so what that means is being prepared looks different, right? So it could be education. It could also be talking to your provider. But I also think we got to talk about the lack of trust. There is a lack of trust with Black and Brown persons in having babies and talking to providers. Who do you really talk to communicate to get the information that you do need? I think that we're training and having classes. It seems like everyone on here is providing some type of space. Providing the space, I think, is really going to create those conversations so that people can come together and really begin to trust, and it looks a little bit different.
Lakeith, do you have some thoughts you'd like to add?
I agree with Dr. Wilder, and then I think Birthing Beautiful Communities. Did you say Kristen?
Krista, yes.
Krista, yes, I totally agree with all that has been said. And if I could add anything to the conversation, I would just add by way of educating, the education that we do with the Black women that we get to serve, is educating them about how to show up in those spaces in the doctor's office, what questions you need to ask. So we're essentially not necessarily educating them in that sense, but repowering them because they haven't lost any power, but repowering them in those spaces so that they know exactly what to expect. And if they're not getting what they need in those spaces, then what is their next move? What should they be doing? So we're educating in a stance that we are repowering our women to be able to use their voices in those spaces so that they get the care that they need, so that their babies reach their first birthday and they deliver full term.
When we talk about getting these babies to their first birthday, Dr. Wilder, there are a lot of opportunities. There are a million opportunities every day, and there are 364 days between birth and getting to that first birthday. So why is that first year so crucial to their future development all along the way, Dr. Wilder?
Well, the first year is crucial because the baby is still developing after it's delivered. So after you go from being a fetus to a neonate, there's still ongoing development. The brain is still forming. And so the environment that the kid is born in, the support that the kid receives within that first year of life is crucial for projection of chronic wellness or chronic illness, as well as projection of mental support and mental overall wellness.
I'm going to share some resources right now that are available here in Northeast Ohio on the topic of child development. Associate Professor of Communication Sciences at Case Western Reserve University, Helen Long, is teaming up with LeafBridge and the United Cerebral Palsy of Greater Cleveland Group to provide free developmental screenings for children ages 0 to 3. So we want to let you know about this because the event is tomorrow, Wednesday, August 19th. That's from 9 a.m. to 11 a.m. And that's taking place in Case Western's Communication Sciences building. You do not need an appointment to attend, but advanced registration is encouraged. We will have a link to register on our website. You can find that on the article for today's show. You can find that at ideastream.org/SOI. Also, there is a brand new resource coming to Northeast Ohio very soon. This is for expecting mothers and parents of young children. A group called RX Kids will launch in Cleveland. This will be in mid-September, around September 19th. The program will provide Cleveland mothers with $1,500 cash payments during pregnancy and also $500 a month for the first 6 months of their babies' lives. The hope here is to minimize the impact of poverty on babies' development. This has been successful in Flint, Michigan, and Cleveland will be the second city that they are offering this cash program in for people who are pregnant and who have just given birth to babies. For now, people who live in zip codes 44103, 44110, and 44114 can enroll in the program. These locations were selected because they have the highest child poverty rate and the 3-year average infant mortality rates in the greater Cleveland area. People can find out more about RX Kids at rxkids.org, and that link will also be on our website at ideastream.org/SOI. Krista, I'd like to ask you about how providing financial support to expectant and new parents might help prevent infant mortality. What are your thoughts on that?
That's going to help to release some of that weathering, that stress that Dr. Wilder talked about earlier, but also just really engaging those social determinants of health. A lot of our clients come to us, whether it's transportation, it's food insecurities, it's really just how am I going to get through the day, right? And we also recognize that even during the postpartum period, right? We know postpartum depression is real. The baby blues is that normal up to 2 weeks, but then after that, postpartum depression, and that is what thrusted me into this work. I suffered from postpartum depression 7 years and didn't even know it. And then we know that it loops back around once you get pregnant again. Within that 7 years, you can go back into it, which is what happened to me. So through education and really being like this lifelong learner to really grasp what it is that I can help and do for myself. And that means community. Who is your tribe? Who is your support? Mental health persons, grief support. However, labor and delivery is traumatic. So we have to acknowledge that trauma and really talk about it. Once we get birthing people to talk about that, we really want to help them to build. So we have them do postpartum plans. Preparedness is really going to help you through that postpartum period. But also when we think about those social determinants of health, we don't have to do everything here. We have a community, right? So who in your community is there to support and offer those additional resources that may be needed at that time?
Lakeisha, what do you think about that, about those types of resources that would be available for people here in Northeast Ohio? Do you think that will have a significant impact on the infant mortality rate in our area?
I absolutely think it will have a really great significant impact. When I think about the cost of living for maybe even a single mother, or for a mother to afford, appropriate housing or adequate housing for herself, or to, work a job that provides adequate wages so that she's able to afford housing that's adequate for her to raise her child. I think there's a lot of gaps within our system, a lot of gaps within our structures that leave a lot of our women that we get to serve without. And so when we think about resources like this that I wrote down, and I'm interested to learn more about it, and when when it's coming to Akron, I think about the women that show up and they, just need a birth certificate, or they just need gas money to get to work so that they don't lose their job, so that they can continue to provide for their children and receive services that they detrimentally need to continue to survive. I think this is an exceptional way to help fill in the gaps, to meet the needs, so that it reduces the stress that our women often carry, so that they can focus on baby, focus on themselves, and focus on healing and getting to the first birthday and beyond.
If you're just joining us here on The Sound of Ideas, we're talking about infant mortality here in Ohio and in Northeast Ohio specifically. The fact that the rate of infant mortality, which is a death from birth up until the first birthday for a baby, is significantly higher here in Ohio and Northeast Ohio than it is across the country. Also, within Ohio and Northeast Ohio, the rate of infant mortality for Black and Hispanic babies is significantly higher than it is for white babies. If you want to be a part of this conversation, the number to call is 866 578 0903. You can also email us at soi@ideastream.org or send us a message on Instagram at The Sound of Ideas. We have an email now in from Jacqueline. Jacqueline says, I would like to comment on this topic because I've been a nurse for many years and in my travels have seen that postpartum hypertension and, of course, preeclampsia is probably more common than not. And unfortunately, oftentimes it is a contributor to both infant and maternal demise. But as far as the Black and brown populations go, fully attributing this to chronic stress in America, can anyone speak to the rates of our mortality here in America versus infant mortality in countries such as Africa or places where Black and brown people originate, because systemic racism is rampant and is a huge contributor to these outcomes? So this is getting back to the issue of racism, which has been mentioned several times here. Dr. Wilder, I'd like to ask you if you could address that. If we're seeing higher infant mortality rates here than maybe we would see in places where Black and brown people originate, as Jacqueline mentioned in the email.
Thank you for the email and the question, Jacqueline. So when we think about all developed countries, Western countries, or countries that are considered to have significant resources, the United States definitely has extremely high mortality rates for both infants and for birthing parents. Comparing the rates of developed countries and underdeveloped countries is like comparing apples and oranges. So the rates are not going to be the same, but when we think about comparing ourselves to countries that have the same resources or the same sort of structure or infrastructure that we have, the rates in the United States are significantly high.
Okay, thank you for sharing that. We have another question here from Audrey. Audrey writes in, how do fathers impact infant mortality? What support is there for fathers in our community? This is from Audrey in Cleveland Heights. And I'll start with you, Dr. Wilder, and then I'll ask Krista and Lakeisha to weigh in about maybe if there might be resources available in their organizations for fathers. But please, Dr. Wilder.
Yes, thank you for that question. That's an excellent question. We cannot leave the partners out of this conversation. And yes, the presence of partners, is thought to provide additional support to the family unit. relieving stress and just having more people and more support there for both the infant as well as the birthing parent. Resources at Metro Health include birthing classes or parenting classes, as well as a specific class for the partner or the father of the baby. It's called Daddy Boot Camp. It is published on our website, and it's a parenting class geared strictly for fathers.
Okay. Krista of Birthing Beautiful Communities, is there anything you'd like to share about resources for fathers when it comes to trying to lessen the rate of infant mortality?
Absolutely. Oftentimes, when we have the opportunity to talk to fathers or support persons, they say that they're often treated like visitors when they come to doctor's visits or in the hospital setting. And so I think allowing them to be a part of the communication when we talk about teen birth, including them in that whole process, and just offering them support as well, which is something that we do at Birthing Beautiful Communities with our classes and in the communities that we serve.
And Lakeish, what about at Project Ujima? What would you have to add there when it comes to fathers on the topic of infant mortality?
Sure, sure. So it's encouraging to see that funding for programming that support fathers or partners is becoming more and more popular because we know they're a very important part of the family unit. And so in our spaces and our conversations that we're always welcoming and opening the doors to fathers and support partners to our program. There's not a program that we have, our event that we're putting together that we're not opening the doors and inviting partners and encouraging our women to bring their partners so that they can also glean the information that we're sharing so they have some understanding of what their partners are enduring, going through, and then offering ways that they can support. And so we oftentimes build programming around what our participants say they need. And so if there's a father in a space who has some needs, then if it's not something that we can actually offer, we partner with a lot of different organizations within the community that we're able to do a warm handoff to. So again, it's encouraging to see funding supporting that. They're always welcome in our space. And then we're also referring them to other supportive resources in the community.
Krista, you've been developing a national nutritional model for families with your work at Birthing Beautiful Communities. Can you tell us about that and the impact nutrition might have on infant mortality?
Absolutely. It's in collaboration with the National Nutrition, Health, and Pregnancy Action Network. And so what we do is we come together with whether it's the CEO of WIC or the USDA administration and really talking about how important nutrition is. One, we've actually identified lack of nutrition or poor nutrition is a public health issue that we absolutely need to continue the conversation and really need to educate our providers. We have a doctor on our team, and he often says how medical providers are not, they have like a couple credit hours for nutrition, right? And so having that conversation with clients is sometimes challenging. So we really want to make sure that people understand that nutrition does really have a high role and impact on people's maternal and infant outcomes. And so educating them on what proper nutrition does look like. So we're hosting classes and cooking classes. And then we even do, when we do our kind of planning with the birth plan, we actually do a meal prep plan. And what does this look like? Because we recognize that sometimes a part of that stress is coming home and not knowing where we're going to get our groceries from or what our next meals are going to look like. So offering that level of support as well. So it's kind of the education then with the support of your doula and then the community engagement, they come in and help them with the resources that they need to feed their families properly.
Lakeish, can you tell us about your event that you have coming up, a Queens Village event? This is under your organization, Project Ujima. That's on Thursday, August 27th.
Sure, it's called Honoring Black Births, Protecting Black Babies. So it's going to be real conversation, community solutions, and then collective action. So our community, I don't think we have done a great job at making sure our community is aware of our infant mortality rates and how they can ask questions and even hold us accountable for what our numbers look like in the programming that we offer to the community. And so we're going to gather community folk, hospitalists, doulas, community health workers, and some of our political activists and leaders in the community to just share our local, our latest infant mortality data. We're going to also share about our Queens Village work and how we're contributing to birth outcomes. We want to hear from our community members and our partners to think about ideas, our gaps, our areas that we may not be addressing, and what our community could do to help us. And so we want them to also know that there's a role in the part that they play, and we would love to hear about how they want to help in reducing the Black infant mortality in our community. And so we're going to gather about 4:30 on that day to do a walkthrough of the Sojourner Truth Plaza, and then we'll have some community leaders posted around the area with some quotes about how they contribute, or how their work or their personal investment contributes to Black infant mortality. And then we'll center around the data and then break off into some small groups to generate some conversation about some of their lived experiences, and then how they might think about moving forward and their participation in that.
Thank
So we
you.
would love to have everyone, join us for that.
Thank you for sharing that with us, Lakeisha. Of course, we'll have a link to that at ideastream.org/SOI so people can be aware of it. Thank you to our panel for participating in this conversation. Joining us on video, Lakeisha Duke, Executive Director of Project Ujima. Lakeisha, thank you.
Thank you.
Also, Krista Lumpkin-Howard, Senior Director of Training and Community Outreach with Birthing Beautiful Communities. Krista, thanks very much.
Thank you so much.
And here in studio, Dr. Jessica Wilder, a maternal fetal medicine doctor with the Department of Obstetrics and Gynecology at Metro Health. Dr. Wilder, thank you.
Thank you for having me.
We'll take a quick break now, and when we come back, we'll talk about a Northeast Ohio physician's new book looking at the caregiving decisions that need to be made regarding high-risk pregnancies. This is The Sound of Ideas. I'm Stephanie Haney. We'll be right back. You're with The Sound of Ideas from IdeaStream Public Media. I'm Stephanie Haney. Thank you for staying with us. In June of 2022, the United States Supreme Court overturned Roe v. Wade with its ruling in the Dobbs versus Jackson Women's Health Organization case, ending nearly 50 years of federally guaranteed access to abortion health care services. This ruling returned authority of how to regulate abortion access to each of the individual states. Doctors and patients confronting high-risk pregnancies have always faced the responsibility of making profound and life-altering decisions, but in the aftermath of the Dobbs decision, those decisions became more complicated. Dr. David Hackney is a Northeast Ohio physician who specializes in maternal fetal medicine and teaches at Case Western Reserve University. His new book, Impossible Choices: A Physician's Guidance on High-Risk Pregnancies in a World Without Roe, explores the considerations of practicing in this area today. Dr. Hackney recently spoke with IdeaStream Public Media's Morning Edition host Amy Eddings about his new book and what his experience has been like as a practicing OBGYN post-Roe. Here's part of that conversation.
The title, is this meant to be a practical guide for doctors and patients?
Yes and no. The book is not a straightforward guidance in the way like you'll sometimes have a book that's guidance on weight loss or guidance on trying to lower blood pressure. But I do intend for the book to have a lot of practical guidance in it. The book is written for a general audience, and it does include specific chapters on common high-risk conditions and how those have been impacted after Dobbs, such as ultrasound to identify potential fetal birth defects, and then say, for example, how state laws surrounding birth defects have changed after Dobbs.
So tell me what your specialty is, maternal fetal medicine, and what your reaction was right after the Dobbs decision, right after Roe v. Wade fell.
Yeah, so on the very night that our state law changed, when SB 23 came into effect, which was the very same day that the Dobbs decision dropped, I happened to be myself on call for high-risk obstetrics, also as you said, called MFM. We are the subspecialty of OBGYN that takes care of pregnancies that are in some ways high risk. That definition, as I talk about in the book, is a little bit complicated because how exactly do you define risk? In fact, having a medical specialty defined by a concept like risk, as opposed to, say, like pediatricians who take care of, children, is always a little bit less straightforward. But we've gone through medical school in the 4 years of OBGYN training, and then there are 3-year fellowships in MFM, after which we only do obstetrics and mostly only see high-risk patients. We are involved in abortion. Abortion is not necessarily something that we're involved with on a day-to-day basis. But there is much overlap between abortion and MFM, and these are often very critical areas.
So let's dig into that a little bit deeper. What makes a pregnancy high risk, and how has the loss of a federal right to an abortion affected those risks, especially in states that have now adopted bans?
Yeah, and there's not a straightforward answer to that question, because it's always important to emphasize that even the healthiest patient with the most straightforward pregnancy itself always carries risks. The risk of pregnancy never extrapolates all the way down to zero, which is why it's important to focus on reproductive rights for all patients, including the patients that I see that are specifically high risk. As a high-risk obstetrician, especially post-Dobbs, I talk about my field because it's what I do. But, viewing abortion bans through the specific lens of high-risk obstetrics is also something that I recognize is complicated also, because, most patients seeking abortion are not necessarily high risk. And a lot of the focus after Dobbs has been on patients such as my patients, patients who are high risk, the patients who have birth defects, the patients who are being forced to continue the pregnancy despite serious medical problem. But that is complicated because that doesn't pick up the lion's share of the picture of abortion, as well as it risks having what we'll sometimes call a hierarchy of deservedness, where my patients that I take care of in high risk shouldn't necessarily be more or less deserving of abortion services than patients who are low risk. I'd like to think if you have, a patient with a serious fetal birth defect, and then you have a 20-year-old who just simply doesn't want to be pregnant but is in good health, there shouldn't necessarily be a hierarchy between those two. The patient with the birth defect tends to endeavor more public sympathy and draw a little bit more focus. But what is the lifetime trajectory of the impact of not allowing abortion care for the completely healthy patient who's 20 and just simply doesn't want to be pregnant at that stage of their life?
Many state bans have exceptions, especially for the health of the mother, more narrowly for cases of rape and incest. Many in the anti-abortion camp argue that these exceptions are clear-cut, and that instances in which pregnant patients have died because they did not get the indicated abortion in time to avoid, say, sepsis or grave blood loss are due to medical negligence and not the law itself. You and many doctors and abortion advocates say it's not clear-cut. Would the problem be solved by explicit language or a comprehensive list of any and all complications? Would that solve the issue?
No, for several reasons. First off, as I talked about similar at the beginning about high-risk patients versus lower-risk patient, if you have an abortion ban, and let's say it could somehow magically come up with a list of all of the maternal or fetal exceptions, that's still fundamentally a violation of basic rights and freedoms. And again, it's important when talking about high-risk patients to always keep in mind the freedoms of patients who are low risk. Also, there are hundreds and thousands of human diseases. You go to medical school and you memorize, textbooks and flashcards, so unless you have legislation that's just, pages and pages long, and even then you probably wouldn't be able to cover everything unless you have bills that are the length of textbooks. You're not ever going to be able to cover every single human disease. And also, in here, I have to, say that I'm a doctor and not a lawyer. Some of the legal issues, start to drift a little bit outside my bailiwick. But we often use the word exception in a not legally exact manner, because there are exceptions and then there is a affirmative defense.
Tell me more about that. What's that mean, affirmative defense?
So again, this is my best understanding of an affirmative defense, but an affirmative defense is a defense that you are allowed to invoke, though in doing so, the burden of proof shifts from the government to yourself. So classically, the government, if it's going to charge you, assumes the burden of proof. But there are some defenses which you're allowed to assume as the defense, but if you do so, you have a shift in the burden of proof. So affirmative defenses vary a little bit from one state to the next, but classic affirmative defenses would be self-defense, entrapment, or
Insanity.
Yeah.
So it's incumbent on me to
insanity.
prove that I'm insane, or have my lawyers prove that I'm insane, or
Yeah, so let's say the government accuses me of having stolen something, and I say I didn't steal it because I have an alibi, I was across town. The burden of proof falls upon the government to prove that I in fact stole it. Let's say instead, however, I say, yes, I did take it from the store, but I was not of a sound mind. I was quote unquote insane, or maybe for some reason it was entrapment or self-defense or something along those lines. Those are affirmative defenses, so I can invoke the defense, but now there's been a shift of the burden of proof. I have to prove that I'm of unsound mind with the burden upon myself. So if you look at abortion bans, you can place conditions into roughly one of three categories. There's a exception, there's a affirmative offense, and then there's a, this is just banned. So if you look at Ohio's law that we were under for many months, SB 23, rape, incest, those were neither an exception nor an affirmative defense. Fetal birth defects, also, abortion was just not allowed under those circumstances. But then the law had 5 conditions which were listed as specifically exceptions. But then everything else fell under an affirmative defense. So, cancer, for example, falls under an affirmative defense. Amazingly, things like heart disease, kidney disease, some of the, particularly critical conditions that we take care of in high-risk obstetrics fell under an affirmative defense, such that if we provided abortion services for patients with cancer, heart disease, kidney disease, and then we had to defend ourselves, since these were not one of the 5 listed exceptions, I, or whoever the physician was, would then assume the burden of proof to demonstrate that the abortion was needed for that health problem.
So this gets to this issue of indecision, or the whole decision-making process, which you also write about in this book. You advise pregnant patients to ask a lot of questions of their doctors in this post-Dobbs era, writing of the potential paralysis that can affect their health care providers as a result of the Dobbs decision. You write very movingly of your own moments of paralysis, both as a doctor and as a soon-to-be first-time dad, when you and your wife had to make a decision about 12 weeks into the pregnancy of your first child. Could you talk briefly about those 2 very different moments? And could you relate it to this idea prevalent in abortion bans of putting the burden of proof on a doctor to say, I performed this abortion because it was in my best judgment that this was needed to protect the health of the mother?
Yeah. One of my goals in the book is to help the public understand how doctors think and how they emotionally are going to respond to these bans. So when I first started writing the book, I didn't know exactly what direction to go in. One of the early books that I read was Dr. Daniel Ofri's excellent How Doctors Feel. And the basic hypothesis of that book is if the general public understands how doctors feel, and of course doctors are humans, and under the immense stress that we also feel under the abortion bans, we're going to respond to things in human ways. The general public benefits from understanding doctors as humans in order to help guide their own best care. If the general public understands perhaps the stresses that doctors are going through, their fears, and particularly after abortion ban sensations such as shame, or potentially falling into decision paralysis, then that helps the general public specifically to navigate these particularly fraught times in healthcare. So part of the book is sort of going through essentially what doctors feel in this circumstance, under these bans. And, of course, we're used to fraught circumstances. We're used to clinical emergencies, having to make changes. We're not used, emotionally to situations in which we know what the right thing is to do, but we're unable to do so under the law. Psychologically, we're not used to the specter of criminal charges, that has taken a significant psychological toll on us. And encountering new things, if it's clinical circumstances, then we should be generally adept at making decisions, including urgent decisions in clinical circumstances. If it's all of a sudden the law and shame and ambiguity, and then there is the potential for us to be frozen, if you will, or not know what to do. And there have certainly been well-reported tragic cases, including cases of patients who have died after the Dobbs decision, where we look back on the case and say they should have proceeded with the DNC procedure. The DNC procedure was obviously, in retrospect, indicated and would have saved the patient's life. And you wonder, why did it not move forward? Of course, we don't know without the actual medical records and everything, but obviously in those cases, there was something that got hung up, be it decision paralysis or administrative. And I think it's incumbent on patients in our modern healthcare system to be able to recognize this and ask the questions you need to ask. As I outlined in the book, if you are in high-risk circumstances, ask in a straightforward manner, would abortion be considered here? Is it legal? If not right now, what would be the changes in circumstances? So I hope that the book helps to empower the general public in that way.
That was Amy Eddings with Dr. David Hackney. You can find more about that at ideastream.org/SOI. If you missed any part of today's show, you can hear a rebroadcast tonight at 9 on 89.7 WKSU. And you can find every episode of The Sound of Ideas wherever you get your podcasts and on the IdeaStream Public Media YouTube page. To get the last word on today's topics, you can email us at soi@ideastream.org or find us on Instagram at The Sound of Ideas. Yesterday, we talked about changes to the federal student loan system that started taking effect on July 1st. And as part of that conversation, we included the fact that borrowers have concerns about not being able to afford their payments under the new repayment plan. Stephen emailed in, I think the main problem with student loans is that there really isn't any way to determine ability to repay at the time of application. No other loan would work that way, and no one would expect a lender to approve a loan without good information on ability to repay. Stephen, thanks for sharing your thought. Tomorrow on The Sound of Ideas, we'll learn about statewide efforts to control wildlife, specifically looking at deer populations in urban areas. I'm Stephanie Haney. Thank you for keeping the conversation going. We will see you back here tomorrow on The Sound of Ideas.